Again, welcome to our Adult Cardiac Surgery Database Quality Improvement webinar for January 21st. This is Nancy. On the call with me today from the STS, we have Emily Conrad, Banu Yatsi, Sydney Clinton, Leanne Jones, Paul Meehan, and Melinda Offer. We will cover a few brief STS updates today, and we have a treat for you guys. We have guest speakers, Deanna McIntire and Marc Burkard are here to speak to us today about their physical therapy program. And then we'll have time for some Q&A after their presentation. So important dates, we'll just quickly go over our timeline. Today's our quality webinar. Our next webinar is the monthly webinar on February 4th, and you are in for a real treat. We are hitting the education really hard on the 4th with aorta education. We're starting at the beginning. Melinda has a really good presentation. Whether you're a novice with aortas or an expert, it never hurts to review from the very beginning. So we'll be talking about some anatomy for aorta, and this is ahead of the launch of our aorta risk model into the Harvest 3 risk-adjusted reporting. So be sure to put that on your calendar. February 18th, we will have another guest speaker on our quality improvement series. We'll be talking about decreasing renal failure. Harvest Close is coming up on February 20th, and then our next monthly webinar after that will be on March the 4th, and we will continue with aorta education at that time as well. Like I said, Harvest Close is February 20th. That'll be here before you know it. This includes cases from January 1st, 2023 through December 31st, 2025. And this is a star rating harvest. The opt-out date is February 24th. Be sure that if you wish to opt out of reporting, that you get that web form completed by 5 p.m. Eastern on the 24th. And again, this is a star rating harvest, so make sure that you are getting your data submitted and cleaned up. Make sure that you're paying attention to the community page and looking at your harvest missing and unknown data, particularly for your mortality analysis, your 2% missing and your data thresholds. And then also checking out our other resources, the missing variable report and your data quality report. If you have any questions about harvesting data, data submission, cleaning up, getting prepared, and such, feel free to email me at nhoneycutt@sts.org, or we do have some resources on the STS website. Last year at this time, Melinda put together a really nice data manager training series, and we had 2 presentations related to data submission and harvest. So if you have questions, if you have time, please review those videos. They're very helpful and contain a lot of great information. Just wanted to announce that we are just beginning to plan AQO 2026. This will be in New Orleans. The dates for that are September 30th through October 2nd. The Intermax and PDMax AQO will be a live virtual forum like we did this past AQO. That will be September 24th. CHSD and GTSD sessions will be held September 30th for a full day and then a half day on October 1st. And then the adult cardiac sessions will be held October 1st for a full day and October 2nd for a half day. The half day sessions for the on-site databases will include breakout sessions. So we are excited to bring that to you this year. So we are getting ready. I know it seems early, but it really does take quite a good bit of planning to bring you a great program. So, all right, I believe that's all of my announcements and updates. So at this time, I will turn the program over to our speakers. Today, we have Deanna McIntire and Marc Burkard from the University of Virginia Health. They're going to present a talk entitled Prehab Power, Enhancing Surgical Success Through Frailty Assessment and Prehabilitation. Deanna is a physical therapist with 27 years of experience at UVA, including the past 7 years at the Cardiac and Vascular Surgery Clinic. She earned her physical therapy degree and master's in health science from the Medical University of South Carolina. Her clinical role focuses on frailty and functional assessments to enhance surgical risk stratification and guide collaborative preoperative care for cardiac and vascular patients. Her research on frailty helped establish UVA's prehabilitation program, and she remains passionate about developing resources that improve surgical outcomes. Outside of work, Deanna enjoys gardening, running, hiking, and traveling. Marc Burkard has been a physical therapist for 30 years. He received his BS in physical therapy from the University of Connecticut. After working at a teaching hospital in Connecticut and as a traveling physical therapist, he joined the University of Virginia Health System in '96. Marc has been working with the cardiovascular patient population for the past 15 years in the ICU, acute care, and outpatient cardiac rehabilitation settings. In 2017, he became board certified in cardiovascular and pulmonary physical therapy. Marc has been involved in the development, design, and implementation of UVA's Prehab program for the cardiovascular population. In 2022, Marc started treating the first Prehab patients in the outpatient setting at the UVA Cardiac and Pulmonary Rehabilitation Center. Outside of his professional career, Marc enjoys playing poker, exercising, and aviation. And on behalf of the STS, Deanna and Marc, we are so happy to have you. We appreciate you accepting the invitation to come speak to us today.
All right. Thank you so much. I just wanted to say it's actually Marc Burkard, not Burkhead. Just to
Sorry about that.
but I'll tease him about that forever. We've
Sorry about that.
We've worked together actually the whole 27 years that I've been at UVA. So it's pretty great that we both get this opportunity. So I'm going to try to share my screen here. So let's see. Okay. And then, sorry, there we go.
We can see it.
You can see it. Okay. All right. So Marc and I have really had a great opportunity to develop our program. It's been something that has taken over the years, just a lot of thinking outside of the box. So we've presented to various audiences in our physical therapy profession, to surgeons, to APPs, locally and nationally. And so what we're finding is that not a lot of people are doing what we're doing. So Judy Smith is our database manager, and she thought it would be a good idea to share what we're doing and just get the word out there. And so that's what we're up to today. So, yeah, so I have nothing to disclose. And so the objective of this talk is to first talk about how, so I'm a physical therapist, but we have a role in our cardiac and vascular surgery clinic. So I am a part of that team. And so I wanted to talk about how we got that approved, and then also just how that role was developed, because it's very unusual to have a PT in a clinic not seeing patients on our own. So just to talk about that a little bit. And then actually part of getting us in there was measuring frailty. And so just to let you know the specifics about what tools that we started using and what we're using now, and how that can be used to not only show objectively differences that we can make, and also to help stakeholders that might be wondering, oh, I'm going to put a PT in the clinic, but they're not billing. So what is the payback with that? So just to talk about that a little bit. And then in doing that, that gave us the opportunity to actually start a prehab program in a cardiac rehab center. So Marc was already, as a PT, helping with the cardiac rehab classes. So say somebody comes in and they've got back pain or they need a hip replacement. And so to have a physical therapist in that cardiac rehab setting to kind of alter the cardiac rehab program so that that patient can optimize what they need to get through their phase 2 of cardiac rehab, but also consider the physical ailments that they may have. So he really kind of kicked us off in that role as a PT in the cardiac rehab environment. And so he, I believe, was part of that proposal in 2017. That's when the buzzword prehab was, or prehabilitation, was up and coming. There have been studies done with abdominal surgery cases, other surgery cases where they were showing if you optimize a patient before their surgery, then their outcomes are going to be better. So he was part of a proposal that got the background on, okay, these patients having a sternotomy with sternal precautions. And so we're in the clinic, so we're really only impacting the elective cases. But the proposal was put through and accepted to get us in the clinic to do education starting in 2018. And lucky for me, I was just coming back from a long stint of doing a wage position, having 4 boys. I worked all the services, did lots of weekends, and then I was ready to come back in a clinical role, and that was a really good timing for me to sink my teeth into something because I was ready. And Marc was also part of that. He was working in the cardiac rehab center, and then we sort of developed what we were going to measure. So having that role, we wanted to optimize the patients before surgery. Wouldn't it be great if they knew their precautions ahead of time, set up their house, if they had other ailments, or if they've had a stroke or amputation or hip replacements, considering discharge options if they're going to need rehab, or special recommendations. And so initially we were just looking at the higher risk patients. But what we found was we're giving the patients all education, and some of the testing, if somebody knows, oh, I'm doing really well, it can kind of diffuse some of their anxiety, and then also give them expectations. And it also I mean, there's so much information coming at the patients. So just to give them a little bit of a heads up on precautions, how to prepare, and it just is going to help with the follow through. So that was kind of what we did, just trying to get together what are we actually going to do. And then, so the idea then is, from a functional physical rehab eye, instead of the doctor's eyeball test where, they are looking at the patient and making an impression, we're actually looking at objective functional and frailty testing, and that doesn't always match what the eyeball test is. And so, this role is just to really give that input. And so just as one piece of the whole risk stratification. So, and what's ideal is that being in the clinic, in real time, I can talk to the surgeon, if there is an option to delay the surgery, depending on what their frailty is, what they might have going on. So just having that information in real time is really ideal. And then also just discussing different surgical approaches if it's an option. So sternotomy versus a transcatheter approach. And sometimes my perspective, the functional piece doesn't always match, what is expected. So at least we're offering different information to be considered. And then, if there's not an option to delay or do a formal prehab session, then we know just to give that patient more support, and all of that is going to just help them through their surgery. So so the education that we provide, really getting them ready for sternal precautions, having them practice. We've gone to the move in the tube, liberalized sternal precautions, and so teaching the patients that, having them practice, talking to them about log rolling, fitting them with SternaSafe. It's a special device that can help them with post-op pain. And then other information, I can tailor it to whatever the patient needs, but in general, we want to do fall reduction, give them a home safety checklist. If they're very symptomatic, work on energy conservation strategies, and then address anything specific, which we have had several special cases. I had a gentleman who at his baseline was a bilateral amputee, used prosthetics, but his main way of moving was completely with his arms. So just to kind of work with him a couple times in the clinic and kind of getting a plan, and he was able to get through his surgery, heal his sternum, get on with his life. So that was a big victory. So looking at the frailty testing, there are so many different frailty test scales. Some are questions, some are ruling out based on the patient's comorbidities. There's a million of them. So we started with the Freed frailty was already built into our medical record system. And so we were using that. And also soon after being in the clinic, we also, any patient that's going to have a TAVR, they have to come through the cardiac surgery clinic to meet the surgeon. And so that group was interested in using the EFT, Essential Frailty Toolset, which had similar components that the Freed did, but it also had a cognitive screen, which is really good. So because there was some overlap in that, we said, well, we'll just do both, because having that mini cog, which is also a test on its own, it's good to have as a cognitive screen. And then after being in the clinic for a couple of years, just for the cardiac patients, we did a proposal and got approved to also see vascular surgery patients, which typically can have more balance issues. So that's when we added the short physical performance battery, which is all objective. It adds a balance component to it. So so the freed frailty, so there's a couple questions based on how the patient responds to their normal activity versus something a little more strenuous, and if they've had unintentional weight loss. And then there's a 5 meter, actually it's 15 feet, gait speed, and then looking at their grip strength. So, and the scoring goes, the lower the score, the more robust they are. The higher the score, the more frail they are. And this has been kind of a gold standard test that's been used for many, many, many years. So let's see. And what I don't love about this test is just there's subjectivity to the answers. The patients can answer any way that they want, as far as it might not be a true measure of their actual function. So, but we do use that one. And then the EFT, so the 5-time sit-to-stand, I think that's a really great standalone functional test. If you have no time, even one time standing up is value. So so that's part of it. And then the mini cog, which is a cognitive screen, if the patient fails that, and that's the clock test, it's a short-term memory test, then we can do the mini mental full cognitive test. And I have, sometimes the surgeons just want that. If there's some mild cognitive, maybe beginning of some sort of issue, even if it's going to be a minimally invasive, a thoracotomy versus a sternotomy, that thoracotomy approach is still time on the heart-lung bypass and can lead to post-op delirium. So the surgeons really sometimes just ask for that test. So it doesn't take that long. And then the other two parts of that test, the hemoglobin and the albumin, those are pre-op labs that the patient will get. And a lot of times the patient sees us, then goes to the lab. So I don't have half of the test to, in real time, say to the surgeon, oh, okay, this is their frailty score. So it is a good test, but just in that real time, not having those pieces can make a difference. And that's why I do really like the short physical performance battery, because it's all objective. So taking out any ambiguity in how the patient answers, it's and it's pretty quick. So, you know, it's 3 10-second positions for balance. It's that 5 times sit to stand again. And then instead of a 5 meter, it's 4 meter walk test, or 15 feet, which actually I don't walk the patients to death. I can get the measures pretty efficiently to do all of these. So I've actually been using all 3 of these more recently, and just to show that the short physical performance battery is a validated test. It can you know, predict somebody's disability coming from the community, as well as predict some adverse outcomes after surgery. So, and it's built into our medical record system, which is great. So unlike the freed and the EFT, the short physical performance battery, the lower the score, the higher the frailty. So it's better to have a higher score. And what I also like about this is it's not just a yes, no on each element, but it can grade, like there's a range of scores. So if your 5 meter is, 12 seconds, it's not just a yes, no, like you failed it or not. And it is a good tool to show improvement, objective improvement. So I think that one is really, really great. Just to compare the scoring, the Freed and the EFT, the lower, the more robust, the short physical performance, the higher the score, the more robust. So, and then between 2019 and 2020, we looked at all the pre-op. So these are all elective patients, most having a sternotomy, but we did have some minimally invasive, so thoracotomy approach patients. And so we looked at their pre-op frailty scores and put them into categories, because initially just being in the clinic didn't, make more fit patients come through the clinic. They're still really, sick people that need surgery or different frailty levels. So we decided, well, let's look at each category, the frail, pre-frail, or robust category. So if we, based on the testing, categorize patients into those groups and then look at the post-op outcomes, that's where we were able to show, yes, let's see, let me show you on this one. If you compare the groups, and we use the Freed frailty, there wasn't a big difference between the EFT and the Freed, and the EFT was not part of the medical record, so it's easier to use the Freed for this group of patients. But you can see if you can just improve, so on length of stay, a frail patient, if you can just improve that frailty by one factor, you can save a day in the hospital, and then even ICU hours or vent hours. And then this was a big deal. We want to have a push for patients to go home. We know they're going to recover better at home for the most part, and we want them to go home. And so just again, if we can improve those frailty from a frail group to a pre-frail, or from a pre-frail to a robust group, you're really making a big difference as far as being able to go home versus needing a facility and then readmission. So the frail group, 23% of those patients were readmitted. We know that is a big deal to be readmitted. And so this really gave us the objective information to really move forward with pursuing a formal prehab program. So the outcome is just that the pre-op frailty testing, really showed that we can identify patients that can really benefit from that prehab. And we found, if you try to send a patient waiting to have a bypass or a valve, you send them to an outpatient clinic and they're going to say, no, I'm not going to do anything with you. And so Marc was already practicing in the cardiac rehab setting a couple days a week. And so we realized, hey, that's a really safe place to exercise a patient. There's, they're ACLS certified. There's physicians on site. They also get a taste of cardiac rehab. So it's an underutilized program. So they're more apt to use it after surgery. And Marc, being a physical therapist, he can bill it as it's outpatient physical therapy. He just happens to be a department of one. So, it's really a different way to kind of think about using your therapist. So, so this is where, again, just looking at the role in the clinic and just kind of thinking outside of the box to utilize our role and have that interaction with the team. And, there are challenging patients that still have surgery, or sometimes we give the information and risk versus benefit. It's really, not the best choice. So, and then just some other parts of being in the clinic. So, this is a picture of the gentleman who did have the bilateral amputations. He actually used shorter prosthetics that did not have a knee joint. So it was extra challenging to get him to transition from sitting to standing without a knee joint and without, pushing with his arms as he normally would. So we practiced the move in the tube. And I actually had to put him on the lowest surface, which even a low bed wasn't low enough. So I had him on a low bedside commode, and then that was low enough that he was able to get up without pushing with his arms out wide. And then once he was up, he could just walk. It was just those transitions that were difficult. And then we have worked just another role of being a PT in the clinic, just looking at equipment. I mean, we do have larger patients that have surgery. If they have a sternotomy, the ladies are going to get a surgical bra, because the breast tissue, when you lay flat, that can put pressure on the incision, can impact how they're healing. And most women say they really feel better with that surgical bra on. So we've had some larger patients, and we've worked with the company to actually manufacture a larger surgical bra. We did the same thing with the Sternosafe, because really those are the patients that are at most risk to have healing issues. So that's just a different way to kind of use PT in the clinic. And we did have a group where we were trying to figure out why there was an uptick in some of the surgical site infections. And so, what we realized in looking at all the factors is that there were differences among, staff in the clinic and at the bedside, and still having travelers and different surgeons. And so I did do an evidence-based review with our surgeons, just to get everyone on the same page and to hear their concerns, because I am not a surgeon, so I don't know what, if they're making certain decisions. I'm certainly not going to tell them what to do, but just I wanted them to think about if they're going to give somebody a precaution or say, you can't drive for 12 weeks. Well, that's a huge independence that affects, your emotional well-being, can be isolated, wouldn't be able to get to cardiac rehab without other arrangements. So anything that they were going to either say as a precaution or tell their patients not to do, we just had a discussion, like, let's talk about what you're concerned about. And there are some cases that, somebody's not going to heal well, so you're going to be more conservative. But in general, just to have everybody on the same page. And then we redid all of our education to make sure what was given in clinic matched the discharge education and what was passed on. So it's still a work in progress, but those are some other things that that we add in that role. And so I guess I will keep going with the prehab part, unless Marc wants to chime in, but I'm happy to keep on going. So as I said, Marc was the one who was in already acting as a PT in the cardiac rehab setting. And as a clinical specialist, he was researching prehab and, looking at different things that he could add as a physical therapist. And so, just looking at if somebody is going to come in at a lower functional status before surgery, and then the stress of the surgery itself, they're not going to rebound as well as somebody who is just going to heal, recover, be more resilient. So and so that just gives more fuel to really get this prehab program going. So based on the study that we had done, we're targeting the frail and the pre-frail patients to impact. And then the inclusion criteria, they need to be able to participate, follow commands. We're only doing the non-emergent patients. And the tricky part with the billing is that there needs to be a window of 6 weeks, hoping that they can participate at least for 4 weeks, because it takes about 2 weeks to get the authorization. And so that is, and then just I guess any other let's see, the contraindications, I believe these can match what the cardiac rehab contraindications are for exercising. And then, just to have a decision tree for, having somebody participate in the prehab. So what's their frailty level? And then do they have any of the contraindications? And then, it's that conversation. Can we delay surgery to participate? And then is the patient willing to attend? And part of that is it reasonable for them? Do they live close enough that they can reasonably come and participate? And I know Marc has been really great lately. If we don't have somebody that lives close by, he will do, like a weekly visit and give them things to do on their own. I think a future avenue with the right patient would be telehealth visits, but there's safety with that. And so that's the original decision tree. And so the program is not just Marc, not just PT, but looking at nutrition and social work if there's social determinants of health. It's, I guess, and if there's medications that need considered, and then any dietary if they're losing weight without trying, or if they've lost muscle mass. And I think this could be an issue with, there's a lot of patients that are on, Ozempic or rapid weight loss medications. And what I found is that they have to work really hard to keep their muscle mass. So nutrition is really, really key with those patients. And we have had them because, yeah, the surgeons want them to lose weight, but if they lose all their muscle mass, that's not necessarily helpful. And then just looking at the different domains that go into what is frailty. And so the physical frailty, these are tests that we typically use. So different functional tests. And then there's many, many, many tests. So there's some more. And then the cognitive assessment. So the mini-cog is the screen that we use. And then the mini mental state exam is an actual cognitive test. And then we've used the MOCA. Those have been more with the transplant patients, but those are some examples. And then looking at the albumin, I believe with the EFT, that's kind of a level of their nutrition, which I think there might be some better indicators now. So, and then I think this is really, really important. And I love that Marc measures this, just somebody's psychosocial frailty. You can have a very fit person who is almost too afraid to even come for their surgery because they're so just anxious, paralyzed and with that anxiety. So or depression, and just to have resources available and to do those objective measures to kind of tee up those consults is really important. So the components of the prehab, really the aerobic part. So I believe that it's not quite as intense as cardiac rehab. So instead of doing 40 to 80% of their target heart rate range, or their training heart rate range, it's between 40 and 60 to 70. So Marc will do the math for that. And he's not going to work somebody beyond their, he's not going to push them through symptoms. So, and this is the education they get in clinic. We do teach them pacing and RPE scales. So getting that education is part of what they're going to rate while they're exercising. And then different components, they can do some strengthening, they can do some stretching. Along with the strengthening, I know Marc has done quite a bit with inspiratory muscle training. So he has different protocols for either strengthening or endurance, and then in different positions. Balance, if somebody's baseline balance is poor, working on that, and then that relaxation, de-stressors, strategies are really, really good to do. And so the education that they receive, it kind of builds on what they would get initially in clinic from me, but also anything specific, like if they need smoking cessation, stress management, nutrition, and really, if they're really struggling with sternal precautions, to give them specific either strategies to alter something, like they can maybe stay downstairs if the stairs are going to be difficult, or the height of their bed, or different ways of working on transitions, and also working with their caregivers as well, or their partner, who also can have a lot of anxiety leading up to surgery. So, and I believe that these are similar instances to terminate their exercise session as it would be during cardiac rehab. And Marc can correct me if that's not the case. And so I know that time-wise, I'm probably talking too long, but I wanted to include, so this was, Mark and I both have done different case studies, but this just highlights the first patient that actually went through our prehab program. So when she came to my clinic, and she was not even considered to be a surgeon. And so she needed a mitral valve repair. And so her cardiac surgeon said, no, surgery is prohibitive. So she looked into some studies, didn't qualify for any. And I believe her cardiologist sent her to Marc for prehab. And so, so I saw her in April. The next January, she actually had improved her sit-to-stand, but still was relatively frail. And then Marc worked with her, I believe it was over 6 months. I mean, just a couple times a week, made really amazing gains with her. And she did have some mental health issues. She was going through a divorce. She had depression and anxiety. She was able, so the lower score for the physical health questionnaire, her quality, she improved with that. And so, yeah, so our surgeon said, okay, yeah, she looks like she'd be a candidate. And after her surgery, she made it through her surgery. She didn't need to be reintubated. She didn't go back to the ICU. She didn't have post-op complications, didn't get infected. She was able to go home with home health instead of needing any rehab. And that was delayed because her INR was not therapeutic. She wasn't readmitted. And what struck me about her is she's somebody who, she was overweight, not the most active person. And she just really embraced, she was somebody that wasn't going to go to a gym. She needed somebody to kind of motivate her. And, just getting the routine with Marc, the one-on-one, she really got into exercising, and it gave her confidence, and you could just see she'd be like, okay, can you test me? And so that's not necessarily objective, but it really makes a big difference. So that is all I have for this presentation. So again, it's a great opportunity. I would love to help other facilities develop a similar program. I feel so lucky, and I want to be a good steward of this position that I have in the clinic. And Marc is doing the prehab and the rehab and the cardiac rehab setting. It's just, I would love to have this just go rampant. So happy to take any questions.
Yeah, thank you so much, Deanna. That was a fabulous presentation. We appreciate you coming to share. I was very impressed with your first prehab patient, excuse me, that you highlighted, that went from being turned down for her mitral valve replacement all the way to having her surgery just a little over a year later and doing well, no complications, extubated on time, and discharged timely, not readmitted, and attending cardiac rehab. That's impressive. Thank you for what you do. We do have,
and Marc did 26 of those visits, so
yeah, very impressive. Thank you. We do have some questions. So what is the financial cost to the patient for the prehab? Have you found that this decreases the post-op rehab that insurance is willing to pay?
I don't believe that so the prehab is billed as outpatient physical therapy. So unless there's a limitation in that, because the cardiac rehab is its own, it's a different billing. It doesn't have to be a PT. It can be an exercise physiologist, but Marc can definitely.
Yeah, Deanna, you're correct. So basically, the prehab is billed under physical therapy services. So depending on what the patient's insurance coverage for therapy services, what their copay is, that's the prehab part. After they have surgery, then they would be qualified for traditional cardiac rehab, which is billed totally separate. Traditional cardiac rehab is not a physical therapy service. It's billed under cardiac rehab services. So they're two separate services. Now, Medicare gives people with qualifying diagnosis for cardiac rehab 36 visits. Depending on a person's insurance for prehab, because it's a physical therapy service, I may only get approved for, say, 10 visits or 20 visits. And if I want them to extend, then I have to go back to the insurer and go through the whole, can you give me another 4 visits and 8 visits? So beforehand, it's physical therapy services. After, they qualify for traditional cardiac rehab.
Thank you.
Mm-hmm.
Do you use the SternaSafe on all patients?
In the clinic, anyone having a sternotomy, we've hit them with that. We want them to use it, but if somebody really is claustrophobic, they don't like anything around them, we're not going to force them to use it, but we want them to use that heart-shaped pillow as a splint. And some of the evidence-based research that I had done, even if you have nothing, just like, crossing your chest, just splinting yourself is helpful. But we do and actually the emergent ones too, they'll get fitted with it post-op.
What were your biggest challenges to getting your prehab program going? And cardiac rehabs are busy. They're not sure they have capacity for these patients.
Yeah, when we first started, obviously we were lucky enough that we had a management team that kind of bought into the concept when we first brought it to them. One of the roadblocks, like Deanna said, was insurance approval. So a lot of times when they get to the clinic and Deanna sees them, their surgery is scheduled probably within 2 to 4 weeks. Unfortunately, for that to get insurance approval, it can take up to 2 weeks to get insurance approval. So that doesn't give me a lot of time to work with people who might need it. So that's kind of one roadblock. The other roadblock can also just, getting physician buy-in. We have multiple surgeons. I get most of my referrals come from 2 different cardiothoracic surgeons. And I get a smattering from a couple of the others. So I think it's more just education. Also, if their willingness to, again, postpone surgery, because we're not working with the emergent cases. I think it's also a mind shift. We're kind of trying to change the practice. I think it's going to happen. I think it's just common sense. If you're in better shape before any type of physiological stressor, you're going to come out on the other side better. As there's more research, I think there'll be more buy-in.
And what is social work's role in the prehab clinic?
So the nice thing about being embedded in cardiac rehab, when I designed this portion of it, I kind of followed the same guidelines that we use for our cardiac rehab folks in terms of contraindications, but also we have a nutritionist on staff for our cardiac rehab patients and a social worker. People with cardiac events, there's a high incidence of depression that goes along with having either cardiac events or cardiac surgery. And that's why we use that PHQ-9. And if my patients score high or they have anxiety about their surgery, which is upcoming, I will tie them in with our social worker so that we can also get them, mentally prepared for their surgery. I also got our nutritionist involved as well so that she can get them, look at their nutritional status, if they need more protein leading up to the surgery, that sort of thing. So it's nice to be embedded in cardiac rehab because everything is already here that I need. I've got, like I said, I've got a crash cart, I've got equipment. I didn't have to buy anything. So there was not, having to find a gym or more space. So if you're trying to do this at your facility, if you have a cardiac rehab place, it really is a safe environment and it's not a big cost.
Very good. We have some data managers on the call who are working to start prehab programs at their site. Is it possible for you guys to share your slides with us? Are you comfortable doing that?
Yeah, I think, yeah, no problem.
Yeah.
Okay, great.
Yeah, and if they have any questions, feel free. I'm sure Deanna's fine. If you need our contact information, I can send it to you. And then folks can reach out to us if they need to, and we'll try to go a little bit more in depth.
Sounds good. Thank you.
Yeah, I did put my contact information on the last slide, but, I could definitely filter things to Marc for sure.
I have your contact information. So if anyone, you guys can reach out to me and I can share that if needed. We have a couple of compliments, amazing work, and thank you. You have a wonderful program. So let's see. What is the workflow for the patient clinic visit? Do they see the nurse and then the APP or the surgeon? And if surgery is recommended, PT comes in. Are there separate visits for testing? Like basically, what is the workflow or the patient flow?
Yeah, it's kind of fast and furious. You've got to the patients come in, they see a lot of different practitioners. So they come in, they get roomed, they get their vitals done, they do a social determinant of health screen, review their meds, and then so that's all. I guess the nurse or the MA will do that. And then the APP will do a review, go interview the patient. And when we first got in the clinic, it seemed, hey, it would make sense for PT to go in before the surgeon does, just so they have the full, if they're making a decision about surgery, so they have the full risk assessment, know their functional piece. And just the reality is it's easier to after the surgeon they've kind of made a preliminary plan than for me to go or Marc to do all the testing. But it has happened that after that, if things look, if the patient's going to be frail or it looks like they're not going to do well or need prehab, that's where I will just follow up afterwards. And there have been some cases, actually, I have another case where it was a patient who he was going to have an open AVR he was in his low 60s, I believe, overweight, but losing weight on Ozempic. He had really bad back pain and knee pain. And so, but he was very symptomatic. So he needed an intervention sooner than later. And just the way he moved, the patient was already consented for open, but the APP said, oh, the surgeon's really concerned that wants your input. And I'm like, well, what if the patient did a TAVR, first, and then his shortness of breath, he's, within days, he feels better. He's already losing weight. Then he can really, participate in cardiac rehab. And then if he needed a back surgery or knee surgery, he would be safe to do that. And say another 10 years down the line, if he needs a new valve, he's in better shape, even though he's older, to tolerate a sternotomy. So it was just like, I just like flipped it upside down. So, but again, it's just kind of, a lot of times it's just, no, we have to do this. I'm just part of the risk assessment. So, but yeah, it's the flow is there's got to be a lot of flexibility, because then we have a nurse navigator that does education. Sometimes there'll be research studies going on, and the patients, you just have to read the room, because you can tell sometimes they are just like completely like they're done. And so I can do follow-up phone calls. Occasionally I will bring somebody back in if they just really need more time or more repetition, or getting them to prehab. But yeah, it's very like, they see a lot of us, and you got to be on your game and flexible and strong communication for sure.
Right, thank you. We have a question about the inspiratory muscle training, and I was curious about this as well. So do you use a certain device, and how do you track patient usage?
So actually, currently, even though Deanna said I do that, I have not instituted the inspiratory muscle training yet. Well, one, I didn't get the funding for the devices. I believe there's an inspiratory threshold device, and I think it may run about $25. So it's basically got a spring load in it, and you can set it to the load that you want the patient to work against. The problem is I don't have the testing equipment to do the initial test, see what their inspiratory muscle test is, what their maximal inspiration pressure is. There is some research out there. I was looking at mostly the physical therapy articles. And they do have protocols for endurance training and strength training, but the last that I looked at, and it's been a while, they didn't really say which is better. And also talking with some of our respiratory therapists, they were going, well, unless you have a neuromuscular disease, your diaphragm is probably just fine. So it's probably strong enough. So that was another reason why they kind of deterred me from following the IMT. But again, I think there is some research out there that is going to show possibly that it can reduce some, say, atelectasis, pneumonia rates, that sort of thing.
Thank you. All right, we've gone a little bit over. If you guys are able to stay, we have just a couple more questions. Do you need permission to use the mini cognitive test? No. Okay. And
not that I'm aware of.
Okay. Which frailty test is used by patients that are going for transplant surgery?
I think it depends what is being transplanted. And let's see, I think that at UVA, they use similar frailty measures. I believe so. In the clinic, I don't do a 6-minute walk test, but for the BADs, the hearts, the lungs, they're going to do a 6-minute walk test, and Marc is going to do that as part of his assessment as well. But yeah, I guess I don't know exactly, depending on, because liver transplants, kidney transplants, they're all going to do something a little bit different. But Marc and I were on a task force, I don't know, probably 5 or 6 years ago, where different teams were looking at all, like best practice of the frailty tests. And yeah, I think that they took pieces of all the ones that we do.
In the other thing, Deanna, they may not realize is we have a separate clinic, which is a heart failure clinic. And I believe that's where most of our heart transplant patients go. And Kathleen, who's another physical therapist, she runs that clinic. So do you see a lot of the heart transplants before they have surgery, Deanna, in your clinic, or just?
They may come through the clinic, but I don't do another round of testing because they've already been seen. But in the heart, so a lot of the TAVR patients, I guess in the valve clinic, they use the KCC Q12, which is it's subjective. It's a questionnaire for the patients, but that's where the case of the gentleman that I flipped him from open to TAVR, I did look at his outcomes on that test. So it's a quality of life questionnaire, and it's divided into different domains. And I mean, he did amazing. His scores were so much better. He went from, like 8% or 25% in certain domains to, 75%, 80%. Like it was a huge improvement. And I think there's value in that. I don't know. I know that that's something that they put in the database for the TAVRs. It's a number that they put in, but I don't know if they do anything with it as far as measuring afterwards. But I was like, wow, this is amazing. Like, all the objective numbers are great, but really we want people to feel better and have a better quality of life. So I think that's a really, really good tool.
Okay. And then just quickly, what is your patient volume, and is there a charge for the initial clinic visit?
So I don't see patients on my own, so I don't bill anything. And I'm sorry, what was the other part of that question?
Case volume. How many patients do you see?
It varies a lot because I'm also seeing vascular patients. So again, just to be really flexible, because our surgeons, cardiac surgeon might have half a day and then a different one the next half of the day, and then others during the week, kind of sliding some in. So I would say, between 4 and 12, like 4 to 12.
Is that per day or?
Yeah. It's going to vary, and that would include vascular patients too. So, yeah, it's just, it varies a lot. And then I think Marc's, because Marc's billing as physical therapy, so there is he's seeing individual patients one-on-one, so there would be a bill for that or charge for that.
Yeah, that's correct. So if she was asking about the outpatient side, I typically, when I start the program, I just do one-on-one. And in terms of my caseload, it's sometimes I'll have 3 referrals all at a time. Then I'll go for a while where they don't send me anybody, and then I'll have somebody. We're a little bit unique, even though we're a big teaching center, we're kind of in a rural setting. So oftentimes, even though people may need the prehab, they live so far away that they can't attend our program. So I think that also kind of limits the usage. But like in the clinic, like Deanna said, the number of people she sees through that clinic probably depends on, it varies day to day based on, is it a follow-up patient or is it a brand new patient they're bringing in? Or are we bringing them to surgery? So her caseload does fluctuate based on the patient they're seeing.
And it's been, after the holidays, it's been very busy. So, but also, these rural patients, that's why we want get the word out and have other people be able to to do programs like this, because it makes sense. And I mean, I can talk about all day long. I think Marc probably could too, but we're here to help, and we want to share our experience and information.
Awesome. All right. I think we'll just take one last question. What is the indication for the 5-meter walk test versus the 6-minute walk test, or the 6-minute test?
You want that, Deanna, or you want me? Me? Okay. There's no real indication. A lot of people, the 6-minute walk is kind of a standard test. You know, they use it in a lot of different settings. I tend to do it in the outpatient only because I actually have the space. Deanna, where she works in the clinic, they really don't have a hallway where she could practically do the 6-minute test. The 5-meter, that's again another gait test that they've used a lot in the research. The reason I used the 5-meter, I included was because there was a research paper that was done that said if you could do the 5-meter in less than 6 seconds, those patients who went to cardiac surgery had better outcomes. And if it took longer than 6 seconds, they had worse outcomes. So I kind of just brought the 5-meter when we were looking at tests. I did it because of that research paper that I looked at. And one of my goals when I work with them on the outpatient side is to get their gait speed, the 5-meter, below 6 seconds. So it kind of gives me a little goal to shoot for the patient. But we use both of them, the 5 and the 6-minute walk, the 5-meter and the 6-minute walk test.
And in my setting, you know, I'm getting a 5-meter, a 4-meter, and the 15-foot walk. Like, it's time efficient, you know, to do that instead of I mean, 6 minutes doesn't sound very long, but in a whole visit, it makes a big difference. So anything that can be quicker and still give you value. And that's again where, you know, all these other factors, that one paper, it was like, hey, this 5-meter walk test, you know, was predictive of all of these outcomes, you know, and you can do that in less than a minute. So it's it's, to me, it's a time factor as well. And then for the transplants, I know that they do 6-minute walk, and maybe looking at more endurance, versus the 5-meter can be indicative of like a shorter distance, other, you know, joint issues that are going to impact patients' ability to maintain their sternal precautions versus just getting shorter breath because they're out of, it's an endurance issue versus a strength, safety, balance issue.
All right. Thank you. Thank you so much for joining us today. We received lots of great feedback in the Q&A. Our data managers are really impressed with your program. Your patients are lucky to have you. Thank you so much for what you do for the cardiac surgery population. And again, thank you so much for speaking with us today. We did have a couple of questions about the STS frailty, and just to provide a quick update on that, the workforce is working on the frailty project, and hopefully we will have more of an update for you guys soon on that. All right. Thanks so much. Thanks everyone for staying over. Thank you guys. And we will see the adult cardiac surgery data managers back on February 4th. Thank you so much.
Thank you for having us.
Thank you. Take care.
Bye, everyone.